Peter, you just said back in the days, and some of us
go back further than
except
others.
for Carol, but
I was definitely there.
Some of us go back to when we only have sulfonylureas and insulin. And we had all the discussion about what type of sulfonylurea is better than the other, which is a total...
How many angels are dancing on the head of this
That's
planet?
right. But we did very poorly in controlling diabetes. Now, Vivian was saying, Fonseca was saying, we have 10 classes, so Bob Henry was saying. Still, we're not doing as well as we were doing. Still, 50% of people are above 7% in this country.
I want to get to that very shortly. But let me just put something on the table. The personalized approach to management is one thing. But are we all in favor of screening the entire American population for diabetes? In other words, should everybody have an A1C periodically?
I think the American Diabetes Association has pretty good guidelines. You look at the patient's family history, their age, their ethnicity, and if they don't have any high-risk characteristics, they should be screened starting the age of 45.
Targeted screening, not everybody, but people who are at risk. You can identify risk based on simple clinical things.
Okay.
But I mean, that is a little controversial. I mean, because even the American Diabetes Association doesn't have a specific policy in terms of massive screening. But now with the advent of the A1C, where people people check lipids, why not to check an A1C?
Exactly where I was going. I see an awful lot of folks preoperatively, and the surgeons, to their credit, have started including that in one of their pre-op panels. And I see 2-3 times a week some person younger than I, and that's getting easier to do as I get older, come in with an A1C of 7, 8, higher. And that person, because of the A1C, is probably going to need treatment. And that's an individualized approach too, right? No?
And the other thing that we haven't discussed is the concept of the pre-diabetes. So those people who are at risk of eventually developing diabetes, which is A1C, when you have between 5.7 and 6.4, you're at a higher risk of developing diabetes. And at one point in our life, we are going to need to be intervening in those people with pre-diabetes if we really want to prevent diabetes.
Well, you know my thoughts on that is that pre-diabetes is a risk factor. But of people who develop pre-diabetes, only about 30 to 40% are going to go on to get diabetes. So you can't go treating 100% of the population for 40%. What we need to do is do better a job of defining who is going to get it.
But these people with pre-diabetes are an increased cardiovascular risk.
No, that's the most important.
But that you bring this up. So let's talk about cardiac complications, microvascular complications. What do we know about the goals of therapy here in a newly diagnosed patient? And specifically, do we know whether or not good glycemic control actually makes it less likely they're going to get microvascular?
Unquestionable. Unquestionable. The evidence is very robust that the better the A1C, the lesser the chances of having microvascular complications. It's clearly that it's going to reduce eye, kidney, and renal diseases.
But of course, macro. We've been, we have to dissociate. Most of us push the glucose primarily for the micro. The macro is much more complex and includes lipids and blood pressure and other factors that many of which we still don't know.
But the interesting thing, I'm sorry, Carol, go ahead.
Oh, actually, but glucose does matter.
It matters,
if you
but
look
it's
at the VA-DT
it's a
study,
relatively minor component.
it is over a short period of time, but if you look at some of the studies that we've all participated in, there are a population of patients who are younger, newer diagnosis of diabetes in which tight control did make a difference for macrovascular complications. So it takes longer.
I agree with Carol.
Yeah.
It takes longer, and also you can't leave the glucose uncontrolled and say it's not going to affect your heart.
No, but
it's going to over time.
Well, that's one of the problems that some cardiologists may misinterpret that. Because some of these studies that specifically have looked at the difference between A1C, so people who are well controlled versus less well controlled, have shown no effect on cardiovascular. But as Carol said, if you meta-analyze all those studies, then you see an effect there. So people should not say, okay, it hasn't shown any effect. 7.5, 8% is enough. No, it's not enough because we still need to look at the small vessel disease.
Much of the negative feeling against glycemic control for heart disease comes from the ACCORD study, where people had advanced disease that was irreversible. and very poor control for many years. And I think that kind of that's what drove the individualization. Those kind of
I
people
was going to
maybe.
say that folds back into what
But
you
remember,
said
the
earlier.
Accord wanted an A1C below 6% with
correct.
insulin
Too-
and all these things. It was
too
a crazy
aggressive,
study.
Too aggressive.
It's more than just glucose, though, is the message.
Well, if it's more than just glucose, what do you do about it? In other words, the only thing you're going to wiggle here is glucose, right?
No. Blood pressure, lipids, and are major components that will affect cardiovascular.
But you would do that in all comers, not just diabetics.
No, but we now have medications. This is why it's become more personalized, is these medications target many of the abnormalities. For example, the SGLT2 inhibitors now are being prescribed for and indicated for preventing cardiovascular disease and in type 2 diabetics at high risk of CVD. We've gone one step further. This is more and more personalized.
Well, let's be more specific. SGLT2s, specifically empagliflozin, has shown a reduction of cardiovascular events in people with already cardiovascular disease.
Okay.
So we're not preventing, we're reducing the risk. Hopefully we can take the extra mile and say, if it prevents in people or reduces in people with cardiovascular disease, why not to use it in everybody?
Which, let me bring this right back, because at the beginning of this discussion about how would you personalize and individualize therapy, you said, well, maybe somebody who's got pre-existing disease or long-standing, perhaps diabetically related, perhaps not, cardiovascular disease, microvascular disease, maybe you wouldn't be as tight with those folks. But now you're telling me maybe we can reverse some of that. So doesn't that really mean that you
Not
It's
reverse.
not reverse, it's prevent death, prevent outcome, bad outcomes from the
preventing
disease.
death, when I read
Yeah.
my textbook, was a good thing.
But we're not preventing heart disease by taking a patient with heart disease. We're not reversing heart disease. We're just preventing adverse outcomes.
Now we have the SGLT2 and the GLP-1 receptor agonists with liraglutide and semaglutide that have also shown a reduction of cardiovascular events. So somehow the recommendations are going to need to be modeled where we're going to need to define how we're going to incorporate those medicines.
Even there are differences between what type of cardiovascular disease were prevented with each of these drug classes. So we're going to have to really home in on this personalization based on what the patient has.